Cardiac arrest is a sudden event where the heart stops pumping blood effectively, depriving vital organs like the brain and heart of oxygen. This condition is life-threatening and requires immediate intervention. Without prompt action, irreversible brain damage can begin within just 4 minutes, and total cellular death may occur in 1 to 2 hours. Understanding cardiac arrest is crucial because it forms the basis for why cardiopulmonary resuscitation, or CPR, is performed. CPR aims to restore circulation and breathing, buying time until advanced medical help arrives. Let's explore how CPR works and why every second counts in these emergencies. CPR, or cardiopulmonary resuscitation, is a manual emergency procedure performed to preserve brain function when someone is unresponsive and not breathing normally. The goal is to maintain blood flow and oxygen delivery to the brain and heart until spontaneous circulation and breathing return. CPR is continued until the person regains a pulse or is declared dead. It's indicated for anyone who is unresponsive, has no breathing, or shows abnormal breathing. The effectiveness of CPR depends on how quickly it started, ideally within 7 minutes of cardiac arrest. Let's look at the science behind CPR and its critical time windows. CPR works by creating a pressure gradient between the arteries and veins through direct compression of the heart between the sternum and vertebrae. This increases intrathoracic pressure and helps circulate blood. Brain damage can start after about 4 minutes of zero blood flow, with irreversible injury occurring after 7 minutes. Total cellular death follows after 1 to 2 hours. However, in cases like near drowning, low body temperatures can prolong survival times. Immediate CPR, followed by defibrillation within 3 to 5 minutes, dramatically improves survival rates. Timing is everything in resuscitation. Cardiac arrest can be triggered by several underlying conditions. The most common causes include coronary artery disease, valvular heart lesions, cardiomyopathies, and heart blocks. Other factors, such as hypoxia from respiratory obstruction, massive blood loss, or hypoglycemia in diabetic patients, also play a role. Additionally, anesthetic complications, drug reactions, electrolyte imbalances, vagal reflexes during procedures, and terminal disease stages can precipitate cardiac arrest. Recognizing these causes helps in both prevention and targeted treatment during resuscitation. Diagnosis of cardiac arrest relies on several key signs. The absence of major pulses, such as the carotid or femoral, is a primary indicator. The carotid pulse is most easily felt in the groove between the trachea and neck muscles. Other signs include cessation of breathing, absence of breath and heart sounds, dilated pupils with sluggish or no reaction to light, skin pallor or cyanosis, and unresponsiveness to stimuli. These clinical findings confirm the need for immediate CPR and advanced interventions. Basic life support, or BLS, is the foundation of CPR. Its aim is to maintain oxygenation in the lungs, brain, and heart through rescue breathing and chest compressions before advanced care is available. The sequence has evolved from the traditional ABC, airway breathing circulation, to CAB, circulation, airway breathing, emphasizing the importance of starting chest compressions first. BLS is the critical first step in saving lives during cardiac emergencies and sets the stage for advanced interventions. Airway management is essential in CPR. For foreign body airway obstruction, the victim should be placed supine on a firm, flat surface, with the rescuer at shoulder level. Techniques include back blows to produce a cough impulse, the Heimlich maneuver with manual abdominal thrusts, and the triple maneuver, mouth opening, head tilt chin lift, and jaw thrust. The head tilt chin lift involves pushing the forehead back and lifting the chin forward. For unconscious patients, the finger sweep method is used to clear the airway. Airway adjuncts like Goedel's or Safer's airway, laryngeal mask airway, or endotracheal tubes may be used if available. After ensuring the airway is clear, breathing is assessed by looking, listening, and feeling for signs of respiration. Ventilation methods include mouth-to-mouth, mouth-to-nose, mouth-to-airway, or using barrier devices like masks or face shields with one-way valves. 2 slow breaths, each lasting 1 to 2 seconds, are given to ensure chest expansion while preventing gastric distension. Proper ventilation is vital to oxygenate the lungs and prevent further complications during CPR. Chest compressions are the cornerstone of CPR. Pressure is applied over the lower half of the sternum at a rate of at least 100 per minute. The heel of one hand is placed on the sternum, with the second hand locked on top, aligning with the sternum's long axis. Shoulders should be locked vertically over the hands for effective compressions. The sternum is depressed about 2 inches in adults, or at least 1/3 of the chest diameter in children. The recommended ratio is 30 compressions to 2 ventilations for adults and 15 to 2 for pediatrics. Advanced cardiac life support builds on BLS by adding advanced equipment and interventions. This includes ECG monitoring, rhythm recognition, defibrillation, intravenous or intraosseous access, and drug therapy. ACLS is essential for managing complex cardiac emergencies and increases the chances of survival when combined with prompt BLS. Let's look at the protocols for defibrillation and drug therapy in the next scenes. Defibrillation is a key intervention in ACLS for restoring normal heart rhythm. Biphasic defibrillators are used according to manufacturer recommendations, typically starting at 100 and 2200 joules. If the dose is unknown, the maximum available is used, with subsequent doses equal or higher. Monophasic defibrillation uses a fixed dose of 360 joules. Pediatric defibrillation starts at 2 joules per kilogram, increasing to 4 joules per kilogram for subsequent shocks, up to a maximum of 10 joules per kilogram or the adult dose. Proper energy selection is crucial for effective resuscitation. Drug therapy is vital in CPR and ACLS. Epinephrine is the primary vasopressor, increasing aortic and coronary pressure, given at 1 mg for every 3 to 5 minutes, 0.01 mg per kilogram for pediatrics. Vasopressin can replace the first or second dose of epinephrine at 40 units IV. Amiodarone is used for refractory ventricular fibrillation or pulseless ventricular tachycardia, with a first dose of 300 mg and a second dose of 150 mg, 5 mg per kilogram for pediatrics. Atropine sulfate is indicated for asystole or bradycardia with hypotension, given at 0.5 mg IV every 3-5 minutes. Lignocaine suppresses ventricular ectopy, and sodium bicarbonate treats metabolic acidosis or hyperkalemia. Identifying and treating reversible causes is essential during CPR. The H's include hypovolemia, hypoxia, hydrogen ion acidosis, hypo or hyperkalemia, and hypothermia. The T's are tension pneumothorax, tamponade, cardiac, toxins, and thrombosis, pulmonary or coronary. Addressing these factors can significantly improve outcomes and prevent further complications. Systematic evaluation for these causes is a core part of advanced resuscitation protocols. While CPR is life-saving, it can cause complications such as rib fractures, gastric laceration or rupture, splenic rupture, pneumothorax, and ischemic organ injury. The prognosis depends heavily on the duration of cardiac arrest and CPR. Arrest time less than 6 minutes and CPR under 15 minutes yield satisfactory outcomes, with about 50% neurological recovery. However, longer arrest and CPR times drastically reduce survival chances. Understanding these risks and outcomes helps guide resuscitation efforts and expectations. Cardiopulmonary resuscitation is a critical skill that can save lives during cardiac emergencies. Understanding the pathophysiology, diagnosis, basic and advanced life support, defibrillation protocols, drug therapy, reversible causes, and potential complications ensures effective intervention. Immediate action, proper technique, and systematic evaluation are essential for improving survival and neurological outcomes. By mastering CPR, healthcare professionals and laypersons alike can make a profound difference in emergency situations.